I'm extremely pleased, humbled and honored to have been invited to come and give this talk at the opening ceremony of the, this International Congress of WAIMH, the first on African soil. And, well, I think even though I'm not from South Africa, but being from Nigeria, I want to say welcome to everyone who has come from all over the world to African soil. And in my native language, I'll say Ekabo, welcome to Africa. I will be speaking this afternoon about reducing the burden of infant mental health problems in Africa. I think it will be quite a different perspective, and a lot has been going on, and there's a lot that we need to see so that we would have a better understanding and perspective of how can we go forward with this situation. What is our collective responsibility? Over the next few minutes, I will be looking at infant mental health in Africa. It's very important for us to look at the mortality gap. Maternal mental health. A lot has been said about the links, the connections between the mother and the child, between the family and the child. What are the child-rearing practices? What are the psychosocial needs of the infants? And again, our collective responsibility. A few months ago, I stood before a class of final year medical students and opened a discussion on infant mental health, its importance, and the risks for infant mental health problems. Barely had I started when I had giggles. These increased to bursts of open laughter, and this spread out around the room. I remained silent before this big class, waiting for the noise to subside, but it took a long while for things to become quiet again. Puzzled, I inquired about the cause of the laughter, and I got several replies and several thoughts. Do we now have to deal with infant mental health, the students asked? As far as they were concerned, the infant was too insignificant, too small, and too young to need the help of a mental health professional, they had thought. Others believed that there were way too many important health concerns to have to think about the infant's mental health. To these medical students, the future planners and policy makers, it seemed so far-fetched and distant, and they had thought I was being petty and ridiculous by introducing this topic. Before the discussion that followed, they had failed to see the importance of infant mental health. The WAIMH's definition of infant mental health captures succinctly the essence, and I'm going to read it through because I think it's very important as a foundation to this talk. The ability to develop physically, cognitively, and socially in a manner which allows infants to master the primary emotional tasks of early childhood without serious disruption caused by harmful life events. Because infants grow in a context of nurturing environments, infant mental health involves the psychological balance of the infant family system. Now, who are infants? There are several definitions of infants. The United Nations, when they refer to infants, they talk about 0 to 12. WAIMH looks at early infancy of 0 to 18, and I know that the Infant Mental Health Task Force looks at 0 to 3. I suspect it is better for us to leave it loose and inclusive as much as possible, so we can capture all these different definitions. And continuing with what the medical students failed to see, these students had failed to see the various components of infant mental health, the promotional aspects, prevention, the treatment, and rehabilitation aspects. They had failed to see that infant mental health impacts later life. They failed to see the links of infant mental health to the health of the mother, the father, and the family, or even links to the social environment and the community. These young health professionals were a few months from graduation, and all of them would have some time of their life have to work in the realm of maternal and child health. but then they had failed to see the links and the importance of infants' mental health. And I thought to myself, I had failed. We had failed. We had failed to introduce this topic to them earlier on and help them to internalize and realize that investing early in mental and physical health of infants is extremely important, and that this will yield optimal profits in the years to come for families, communities, countries, and the continent of Africa. They were unable to appreciate that current research reveals that investment in mental and physical health should start at conception and continue right through gestation, delivery, and thereafter. Bridging the training gap, I believe, would be one of the most cost-effective ways to reduce the burden of infant mental health problems on the African continent. But there are several other gaps that we need to contend with. Several other gaps that require urgent attention. And for as long as these gaps remain, the cries on the continent will persist. When I think of infants, I think of many things. I think of happy smiles, beautiful eyes, babbling sounds, breastfeeding, changing nappies, but then I think of cries. When a woman goes into labor in my culture, a prayer is said. And I could see from a lot of the singing that went on earlier on, you could see we're very spiritual people. A lot of prayers are said. And the prayer that is said in my native language is, at the end of the labor, may we hear the happy voice of the mother and the cry of the baby. A very important prayer indeed. Infants cry at birth. They are cries of joy at the birth of a child, especially from the mother. But many times on the African continent, these cries are short-lived. Sometimes you could have a very weak cry, or a high-pitched cry, an unusual cry, a pointer to some change in the infant's mental health. Or it could be the cry of the mother at yet another loss. Do the men cry? Do they cry too? Yes, they do, but in different ways, because in many cultures it is not acceptable for a man to cry openly. But whatever the situation, there are a lot of cries on the African continent. There's Africa's high infant and maternal mortality rates. The mortality cries remain strong on the continent, and these have serious effects on infant mental health. And I think it's very important for us as we gather to look at infant mental health, to also look at the mortality gap on the continent. Virtually all social and health interventions for infants on the African continent have focused on the major causes of mortality: malaria, respiratory tract infections, gastroenteritis, meningitis, HIV/AIDS. And this has led to the neglect of mental health issues and social problems. Although serious problems with mortality persist, there's clear evidence that the mortality rates of infants, children, and mothers are declining. So there's a need for social and health interventions to move towards creating a mental health promoting environment for the infants who will remain alive and form the future of this region. We need to explore what are the links between mortality rates and the neglect of mental health. Perhaps bringing in infant mental health interventions would help to hasten closing up this mortality gap. About 12 years ago, 189 country heads signed the Millennium Declaration with 8 MDGs to bring about development. Although mental health was not mentioned directly in any of the 8 goals, but if you look very critically at them, all the goals are related to mental health, and the attainment of 4 of these goals are directly related to a reduction in the impact of infant mental health problems. MDG 4, reduce the under 5 mortality rate by 2/3 by 2015, reducing the maternal mortality ratio by 3/4 by 2015, reducing the number of people who live on less than $1 a day by 2015, and of course, gender equality and empowerment of women. very closely linked to infant mental health issues. What is the situation on the continent with 3 years to go to 2015? What is the situation in Africa? If you look at the under 5 deaths from 1990 to 2011, you can see that Africa is lagging behind the rest of the world. In 1990, there was just 33% of the infant deaths, or the under 5 deaths, were from Africa. But in 2011, even though there's a drop in the number of deaths worldwide, the fraction from Africa is up. This is a marked contrast to the improvements in North Africa and the Middle East, where they have a decreased fraction, and this is displayed on this. You can see that in 1990, 33% of the deaths were from sub-Saharan Africa. But right now, it's almost 50-50. 49% of the deaths, under 5 mortality, come from the continent, sub-Saharan Africa. There needs to be something done about this. This is in sharp contrast to North Africa's contribution to the world's under 5 mortality. So how many countries in the world will be able to reduce under 5 mortality rates by 2/3 by 2015? If you look at the red portions on the maps, you would see that virtually most of sub-Saharan Africa is not going to achieve this. In fact, there's only one country in sub-Saharan Africa, that is Madagascar, that will attain this by 2015. 8 other countries would be able to attain this by 2025. That is Eritrea, Ethiopia, Malawi, Rwanda, and Sierra Leone. But most of the countries in sub-Saharan Africa will not, at the present rate of improvement, will not have attained this even by 2040. And of course, we all know that the interventions for infant and child mortality continue to consume the available resources for health. And when an infant dies, several others will develop a long-term disability, including mental health problems. This is clearly displayed in a clinic in Nigeria, where we looked at all the children who came over a 2-year period, and we found that 29% of them had had various forms of obstetric complications, including birth asphyxia, and we all know the complications that come from that. How about the maternal deaths? Worldwide, maternal deaths are declining, but what's the situation? Again, Africa continues to lag behind. We can see from this bar charts the maternal mortality ratio per 100,000 live births. The world in blue, developing regions slightly more, and then the developed regions way ahead of the developing regions. Now let's look at Africa, the different regions of Africa. You can see that North Africa and the Middle East are doing quite well. They're right down there, the first blue bar. And then you have Central Africa not doing too well. East Africa also right up there, right from 1990 to 2000 to 2011. If you look at Southern Africa, initially in 1990 it was quite low, that's the purple. But in 2000 it went right up, and I believe that was due to HIV-related deaths of mothers, and then it seems to be dropping again. But West Africa is not doing very well. So we're still a far cry. And for every woman who dies in pregnancy and childbirth, several other women and their infants will develop a long-time disability. This is a study that was done in a hospital, and you can see of the women who came to be delivered, 2.8 had died, but then 35% had different forms of complications. What can we learn from this as we explore the realm of infant mental health? Maternal complications are 12 times the proportion of maternal deaths. Why are the maternal mortality and morbidity findings on the continent so dismal? What access do women have to quality care during pregnancy and childbirth? There's very strong evidence now that suggests that having a skilled attendant at birth and access to basic emergency obstetric care can reduce maternal deaths. But even when it's available, for various reasons, there's no guarantee that these women will take it up, for various reasons about the way it is arranged. So the vicious cycle sustains the mortality gap on the African continent. Less than 20% of deliveries are attended to by skilled health workers. And of course, because the under-5 mortality rates are so high, children are perceived as insurance for old age. So women continue to have more and more babies. The gap between their having babies is very, very short, and they have many children. Many of them have up to 5, 6, 7, 8 children. Grand multiparity is quite rampant, and of course we all know the attending risks that go with that. So the mortality and morbidity gap persists. This is the Millennium Development Goal 5 attainment by 2015. And you can see once again that most of sub-Saharan Africa is in the red. That is, the goal of reducing the maternal mortality ratio by 3/4 by 3/4 will not be achieved until well past 2040. There's a lot of work to be done on the continent. The mortality gap is closely linked to the maternal mental health gap. Research suggests that the prevalence of maternal mental disorders is significantly higher in the mostly low-income countries of Africa because there are a lot more stressful life events. I know we have the supportive family to go, but many times there's so many other issues. On average, about 20 to 45 pregnant women were found to have these various forms of disorders like depression and anxiety. What are the risk factors for these maternal mental health problems? Being single, divorced, or separated. Being a single woman in many parts of Africa is not acceptable. And a woman who is in this condition is more likely to have a mental health problem because it's not simply more stigmatizing, it's socially unacceptable. And then we have a lot of polygamous setups. Polygamy has been found to be a source of marital disharmony and constant friction. And of course, women who are in this situation tend to perceive lower spousal support and a perceived lack of social support. So these are some of the issues that many African women have to face. Another important risk factor is the mode of delivery. Many cesarean sections in Africa are unplanned, and many are done for unbooked patients who had complication. Maybe they went to a local place to have their baby, like a religious setting, and developed complications, and they were rushed into the specialist hospital. And we still have a lot of complications following these operative procedures: maternal sepsis, morbidity, and mortality. Another very important aspect is the pride of an African woman lies in her ability to deliver her baby with minimal assistance. I've seen mothers who would have had 2 cesarean sections, and they would stay at home while they're in labor waiting for the baby to come out because they want their sense of pride to be restored, showing that they can have a baby without an operative delivery. All these are issues that need to be addressed. Another very important issue is the issue of adolescent mothers. Among the Maasai of Kenya, a girl is married up at the age of 12 as soon as she undergoes a very harmful, disturbing process called genital cutting. Some people call it genital mutilation, and other people describe it as female circumcision. In many parts of West Africa, girls are married off at the ages of 12 and 13. In fact, a girl is not allowed to have 2 menstrual periods in her home before she's moved off. A study in Nigeria showed 2% of women married by age 10, even with the Child Rights Act. 8% by age 12, 25% by age 14, and 40% by age 15. There happens to be a very important law leader in my country, and everybody knows he took a wife who was 13 years old, and he still remains in the law, a place where they make laws in the country, as an important politician. So there are lots of risk factors. We all know that when there's a pregnancy or childbirth, the adolescent girls have many more risks for having maternal mental health problems. Girls who give birth before the age of 15, 5 times more likely to die in childbirth than women in their 20s. Not only is it stigmatizing, but there's a lot more risk. And then there are the consequences of maternal mental illness. Studies that have been done and found that many times half their babies are no longer breastfed. We all know there's a common myth around that reveals that sometimes, even when the mother wants to breastfeed and she's mentally ill, the family will take the child away because they believe that the illness can be transmitted through the breast milk. 1 in 10 babies died. 1 in 10 needed hospitalization for physical illness. 1 in 5 husbands left their wives when they had a mental illness after having a baby. The devastating effects on infant mental health. Now, what child-rearing practices can we identify in sub-Saharan Africa? I must say that there are a lot of positive child-rearing practices. One of the themes from this Congress takes a village to raise a child, the communal living, the support, and so on. But then there are other very important issues that we need to look at. A study was done, and they followed up infants for 2 years, and they found that at birth, they had the same levels of development with the Western children. But by age 2 years, these low socioeconomic children had fallen back on all measures of growth and development. What will be responsible for this? Will the problems be physical hygiene? We have a lot of infections, due to infectious diseases and malnutrition. And also we have problems with diet. And we know that diet is not just based on availability of resources, but on cultural preferences. There are many cultures where it's believed that children should not eat certain things. And then also in terms of food distribution, usually it's hierarchical. The father gets the best food, and then the male children, and it goes right down. And so whatever is left is shared by the little children. And this could have a lot of effects. Another very important child-rearing practice is that traditionally in many cultures, young children have no contact with their fathers until maybe they're adolescents. What are the implications for this on infant mental health? And then other aspects that I mentioned earlier, infant female genital mutilation. Studies still suggest that this is practiced. A lot of young babies on the 8th day, female babies, they have parts of their genitals cut off because of beliefs in the culture about the need to do this. Some young women also have this when they're older. Other aspects that we need to look at: husbands not being allowed to get into the labor room because there's a belief that it will prolong the labor. Scarification and tribal marks on babies, sometimes on their bodies. This was a young 3-month-old baby who had seizures, and a traditional healer applied scarifications right across on the body. And then we also need to look at psychosocial need gaps of infants in relation to their health and development. There are a lot of infant nutrition gaps on the continent. A relative lack of protein and energy. A study was done, and it was estimated that 28%, 9% and 38% of children less than 5 were either underweight, wasted, or stunted. And malnutrition starts in the intrauterine life, continues through infancy, childhood, and increases with age. A study in southwestern Nigeria found that 18% single newborn infants were malnourished, and that the prevalence of stunting started about 1 in 4 children from infanthood, age 6 months to 11 months. Several million children on the continent affected by iodine deficiency disorders, and we know the implication of that for intellectual disability. In many communities, mothers still are not able to carry out exclusive breastfeeding. About over half of mothers were found still to give water to breast milk, and many of them were given other supplements in the first month of life. All these are due to a very complex sociocultural, family, and economic circumstances. Inadequate food availability, frequent infections, worm infestation, and very important HIV/AIDS. We also have to look at the magnitude of developmental delay, perinatal asphyxia, like I mentioned earlier, associated with a wide range of chronic disabling neurological disorders. And this happens quite often. Another aspect is the very important aspect of the maternal mental health again. A study found that infants of mothers with depression weighed significantly less than those whose mothers were all right. And of course, we know that depressed mothers' infants had higher episodes of diarrhea and other childhood illnesses. So what is our collective response to this? Very important, teaching and training. Teaching and training. In most parts of sub-Saharan Africa, I believe, very little is known about infant mental health. We need to get out and get involved. Let the mothers and their babies live, closing the mortality gap. Promoting maternal mental health, reducing the risk factors that I mentioned earlier. Encouraging mentally healthy child rearing practices. Infants are not spilled water. Many times when a mother loses a baby, there's a saying in my culture. They would say, oh, don't worry, the calabash, a calabash is like a little, it's something of fruit that we get. So the calabash is not broken, only the water has spilled. Infants are seen as spilled water, that the mother is still alive, but then it's only the water that... So these are attitudes and practices that we need to change. Every life counts, every life is important. We need to meet the psychosocial needs of infants through nutrition, stimulation, and other mentally healthy environments. And I feel that the training in infant mental health should be coordinated and well-planned training programs, a two-pronged approach. Highly skilled personnel should undergo training, and then other advocacy awareness, schools, religious centers, primary care, about the importance of the foundation for infant mental health. I mentioned earlier, let the mothers and infants live. For as long as we have high infant and maternal mortality rates, the focus will be off. Promote maternal mental health. Mothers need to be empowered to be able to look after themselves. And of course, the other people in the environment need to understand the links between them and the children and the rest of the society. We need to deal with child rearing practices. Those that are good, those that promote mental health should be encouraged. And those that do not help young babies should be spoken about and gotten rid of. And of course, we know that child rearing can only work in concert with poverty alleviation and also enforcing the Child Rights Act. Also taking care of the psychosocial needs of these children. They need to be stimulated and people need to be aware. Very, very important is partnerships. Partnerships, partnerships. Partnerships between the developed and the developing world are a major avenue through which the gaps in infant mental health on the African continent can be closed up. And I quote, the developed world has much to give and receive from working with partners from the developing world. If each infant mental health service in the developed world established a partnership with a similar organization in the developing world, much will be gained on both sides from this process. There will be mixing, there will be learning, there will be giving, there will be taking. These links would provide training and educational support to the developing world. Simultaneously, professionals and the community will work together to develop infant mental services in the developing world using creativity and innovation. I was just speaking to a colleague earlier on today and he said in his part of the world they've opened 20 centers for infants. I don't think there's a single one in my country. And who is to say that these same innovations cannot be applied in the developed world? This relationship would also provide reality checks, especially for those working in better resourced areas, and may question whether resources are really the issue. Our collective responsibility, I think we need to send out a unified message. Very, very important. Not only from the infant mental health specialists or professionals, but also those who work in child and adolescent psychiatry. We need to unite together. We need to speak with one voice and not be fractionalized. And let everyone know that the foundation for development of mental health starts in the womb and goes through to the infant. We need to work together and not send out different messages. And this is where I believe WAIMH is doing very well by linking up with organizations like IACAPAP and other organizations so we can speak with one unified voice. And that is our collective responsibility to come together. In any case, traditionally in Africa, an infant belongs to the community. So everyone in the community sees to their care. Everyone within that community feels that they have a role to play in the upbringing of that infant. And that takes place with all the various factors I've said. And these issues need to be tied up and dealt with together. The time is ripe, and we need to start now. We need to get out and do and move infant mental health on the continent forward. Thank you. World Congress of the International Association of Child and Adolescent Psychiatrists and Allied Professions, July 21st to 25th, 2012. And also to invite you back again here in 2014, when South Africa will again host the IACAPAP conference in Durban. Thank you very much.